What's your like next line of what you need to do?
Find out where the bleed is.
Yeah. So who do you call?
Who does that?
GI.
Yeah. So GI. So we would want to scope. Then what else? What other imaging studies can you get? There's like 2.
Can you do like the PO contrast, the CT?
Not PO contrast. That's not going to help you. Oral contrast is not going to help you.
Special kind of CT that's good for looking at blood vessels.
The CT angio.
Yeah. So CT angio, right? And there's actually another study that's not. It's a nuclear medicine. Exactly. It's a nuclear medicine. Exactly. So a tagged red blood cell study. And then GI doesn't work. Who's the other friend of ours that can try to help save us from having to get a big laparotomy with us? IR. Yeah, so IR, the GDA example, so they could embo this, right? Gets a little squirrely when you start emboing like branches of, say, the colon, right? Because say you have some diverticular bleed and they go and embo something, say like a sigmoidal branch, you're at risk of causing ischemia. So that's when we get, super worried about that. And then surgery is kind of end of the line, or somebody who is failing any of those types of less invasive conservative treatments. Different places you read will say like X number of products and things like that, but a continued unstable patient who's failing all these other things needs us to take a look. The problem becomes when you can't isolate it, especially in like a lower GI bleed, right? You can't isolate it, then what?
Subtotal
Yeah,
colectomy.
like basically you're
That's
gonna
typical.
commit to like a subtotal colectomy in that particular, which sucks, but it's life-saving if it has to be. Good?